It is a delight. I'm really honored to be here today and excited. And a shout out to all my friends that are online. Like you said, I am from Tobago and I've been in the United States for several years, but it's absolutely a joy today to talk to those that are on the line. But before we get started, it's not so good to fall asleep during a sleep talk. So I know people may have been sitting for a couple hours, so I hope people could just catch a stretch right now. And while you're stretching, you could grab a book and pen and paper, because I want to make sure you take notes during this session, because there's specific things I want you to go back to your physicians and ask about. So grab a book, grab pen and paper. And if your significant other or family members are outside doing things, bring them all inside so that we could all hear. And I know I stand between lunch and the afternoon for many people. And so I'm hoping that by the end of the talk today, you would not only have had your physical lunch, but you would have had some additional educational food so that you could take with you. So again, a delight. So in the next few minutes, we're going to be talking together about sleep apnea and heart disease. I know it may sound a little odd because we've been hearing about sleep apnea all morning, and it seems to be more related to respiration and the lungs. And so I am going to change the focus. So let's review what we've heard so far. We've talked about apnea and the fact that apnea is complete closure of the airway for more than 10 seconds. Now, there's also another term which is called hypopnea, which is partial obstruction. The airway is not completely closed, it's partially obstructed. And during that period of time, you also get decrease in your oxygen level. Now, one of the things that we calculate in the sleep business is what we call the apnea hypopnea index. And that is throughout the night, the number of these two episodes that you have in 1 hour. And so the abbreviation for that is AHI. On the next slide, I am going to review again what happens in normal breathing and what happens in obstructive sleep apnea. So on the left, we see the airflow, the green arrow. There's normal airflow here, flowing directly into the lung without any obstruction. That's normal. On the right, though, you could see that there is blocked. You see where this blue arrow is, the airflow is blocked. And the thing that's blocking that airflow is, it looks like the tongue could fall back. And so the air is not getting directly into the lung. So that is obstructive sleep apnea. Obstructive sleep apnea is often defined as whether it's mild, whether it's moderate or severe. And that is determined by the number of times you stop breathing, because that's actually what happens. So if you stop breathing more than 5 times and up to 15 times in 1 hour, it's considered mild. Moderate is 15 to 30. And if you stop more than 30 times in 1 hour, that is severe sleep apnea. Now, you may say, well, what happened if I stop breathing 2 to 3 times? That's still within the normal range. So 5 or less is within the normal range. So we will accept that. Now, let's look at the burden of obstructive sleep apnea. As we look across the globe, you have 22 million Americans having sleep apnea. It tends to be more prevalent in men than females. If you have obstructive sleep apnea, this is very important, you are 4 times more likely to have a stroke. And I'm not talking about having other things. I'm talking about, let's say you do not have high blood pressure, you do not have any other risk factor for stroke. All you have is obstructive sleep apnea. you are at risk for a stroke. 38,000 people die from that have sleep apnea die from heart disease. So there is a connection between obstructive sleep apnea and heart disease. The two important statistics I want us to bear in mind today is the next two. Number one, 80%, I'll say that again, 80% of people with moderate to severe sleep apnea goes undiagnosed. And that is a problem because what that results in is a huge economic burden, anywhere from 65 to 185 billion dollars. And the simple reason for that is because untreated sleep apnea can cause several, and I say again, several heart problems, and we're going to talk about some of those today. And so you could see treating obstructive sleep apnea can save insurance companies money. It can save you money. So it's very, very important that we address this. And I'm delighted that we can talk about it today during this World Sleep Day. So the question you may be asking is, how do I know if I have sleep apnea? And I see several people in the audience. Let's talk about this because this is absolutely important, because you may be walking around with obstructive sleep apnea and not know it. So we're going to talk about some of the signs of obstructive sleep apnea. Number one, we heard earlier about snoring. Loud snoring can cause a lot of people who have loud snoring have obstructive sleep apnea. But important to know, you can have obstructive sleep apnea and not be a snorer. I'll say that again. You can have obstructive sleep apnea and not be a snorer. But we know that up to more than 50% of people who snore loudly have obstructive sleep apnea. And the part about this, and we heard this earlier too, is that the loud snoring often affects the bed partner. And so often the bed partner can lose up to 1 to 5 hours of sleep by that loud snoring bed partner. The other thing that happens as a sign of obstructive sleep apnea is witnessed apnea. Very often you may be sleeping next to someone, they're snoring, and all of a sudden there is silence. And you look over and you wonder, are they breathing? No, they're not breathing. They stop breathing. And as they resume breathing, sometimes you would hear snorts, all different kinds of sounds. So witnessed apnea, if you notice that, it's important to review that or bring that to the attention of your doctor. I will give you a scenario, and this is a true scenario of a patient that I had. 26-year-old with a 2-year-old and a 5-year-old. He was a very loud snorer. And every single night he would stop breathing. And what his wife would do is would nudge him with her elbow to wake him up. So he was used to that. Or she would push him to roll over. So every night the wife did this. Now, one weekend, there was a game on, and he decided to go to watch the game at his friend's house. The game finished, and he fell asleep. Unfortunately, at his friend's house, his wife was not there. So he went to sleep, he stopped breathing, and there was no one there to nudge him to wake him up. The end of that story is that 26-year-old with a 2-year-old and a 5-year-old died at his friend's house that night. And so we will talk later about what I like to call aiding and abetting with bed partners. And it's very important for us to be aggressive. If we see this, we need to act on it so that it doesn't come to the point where the person sleeps elsewhere and there's no one there to wake them up. Waking up gasping for air. How often we hear this? I wake up short of breath, choking. These are all signs of obstructive sleep apnea. There's obstruction, and as a result of that obstruction, there is a message sent to the brain to wake you up, and as you wake up, you're gasping for air and choking. The other one we often hear about is excessive daytime sleepiness or fatigue. During the day, falling asleep at 9 o'clock in the morning, 2 p.m. in the afternoon, that's abnormal. Because if you had a good night's sleep, you would be up and about, ready to take on the world at 8 o'clock in the morning. And let me make a note here about coffee. I hear all the time, I cannot get going without my cup of coffee in the morning. You have to wonder if the coffee is masking anything else. And often the coffee may be masking that excessive fatigue that you feel from not having good sleep. And so you need the coffee to wake you up. So excessive daytime sleepiness. And this becomes important because very often people with excessive daytime sleepiness, they drive. And that's why in the transportation industry, we have so many accidents. Or during the day at work, they may be called lazy or falling asleep during an important meeting. That is not normal. So excessive daytime sleepiness that needs to be addressed, and fatigue. Unrefreshed sleep, we talked about that. If you've slept 8 hours, 10 hours, when you get up, you should feel as if you went to sleep. If you get up after sleeping 8 hours and you could sleep another 3 hours, that is abnormal. Another one is dry mouth. And often the mouth is dry because you have been snoring and your mouth is open and it feels dry when you wake up in the morning. The next one is morning headaches. You notice I'm going through each of these individually because I want everyone on the line to be thinking about this, because I think sometimes sleep apnea has been a sleeper. We have not faced it head on, or we have not recognized what are some of the signs of obstructive sleep apnea. That's why I'm taking the time to go through each of these. The other one is morning headaches. When you wake up in the morning, if every day you wake up, you have a headache, that needs to be addressed. Because when you have sleep apnea and you stop breathing for those 10 seconds, during that period of time, enough oxygen is not getting to the brain. And often that's reflected as residual headache. So some people who have been waking up or telling everyone they have migraines for years, you may want to reconsider this to ensure that it's true migraine headaches and it's not something else that you have that's masking the headache. Mood disorders. Many people have been treated for depression and anxiety because of obstructive sleep apnea, and again, the hypoxia associated with this. Memory loss and foggy memory. Sometimes I have patients say, I am just not as sharp as I used to be. I had a patient once that first came with his wife, could not tell me his address. His wife had to write it on a paper such that if, in case I asked him, he could show me the paper. He was very fatigued during the day. We did the usual testing, the workup, and found in fact that he stopped breathing 96 times in 1 hour. He started treatment for his obstructive sleep apnea. And after a year, he came back. And the first thing he said to me, Doc, guess what? I know where I now live. For the first time, he could tell me what his address was. Why am I telling you this story? Now we know that there is a connection between obstructive sleep apnea and early dementia. So not everyone that's showing signs of dementia, it's sometimes it could be reversible, because if it's due to persistent hypoxia due to obstructive sleep apnea and that is corrected, some of that memory and that foggy memory can return. So memory loss and foggy memory, not as sharp as you used to be, it's time to bring that to the attention of someone. Now we're talking about obstructive sleep apnea and heart disease. How is it connected? Now, there are certain cardiac symptoms that you may have that could be reflective of obstructive sleep apnea. And what could some of those be? The first one is resistant hypertension. Resistant hypertension means you are on more than 3 medications for your blood pressure, maximum dose, and it's still not controlled. Yes, that is abnormal because resistant hypertension, you now have to look for what could be causing this. And obstructive sleep apnea, again, could be one of the causes of resistant hypertension. So why am I sharing this with you? Well, if you're in the audience, you have high blood pressure, you taken 4 or more medications for your blood pressure, it is still not controlled. On your next visit to your doctor, I would like you to ask your doctor, do you think I would benefit from testing to make sure I do not have obstructive sleep apnea? The other one is unexplained shortness of breath. I've had many young people come and they're just short of breath all the time. All the testing as far as the lung, it's all normal. There's nothing wrong with their breathing. Their pulmonary testing is all normal, but they just feel short of breath all the time. Again, with obstructive sleep apnea at night, because you're having these intermittent episodes of hypoxia where you stop breathing, lack of oxygen, during the day, what happens is that you're trying to catch up. That's why you see sometimes people yawning at 9 o'clock in the morning or yawning at 2 o'clock in the afternoon, even after sleeping 8 hours. So that's another thing, of unexplained shortness of breath. We need to look elsewhere. How about palpitations? We hear that all the time. I feel like my heart is skipping. Well, it in fact may be skipping. And that could be from either premature beats that are coming from the top of the heart or the bottom of the heart. The other symptoms that we could see related to the heart are abnormal rhythms in the heart. And those abnormal rhythms could be fast rhythms or they could be slow rhythms, whatever it is. And we'll talk about one in a little more detail, one that is common and one that we see a lot of in obstructive sleep apnea. The other thing that I see is chest pain at night. Many patients wake up at 2 a.m. in the morning complaining of chest pain. During the day, they're fine. They're walking around, they exercise, they go into the gym. No chest pain with exertion, just that chest pain that wakes them up at 2 a.m. in the morning. Again, we have to consider what's going on at night that can cause chest pain. And we go back to obstructive sleep apnea with hypoxia. Similarly, congestive heart failure. Several people have exacerbation of their congestive heart failure at night. 2 a.m. in the morning, they're going to the hospital, can't breathe, short of breath. They get to the hospital, they get medicines to cause them to go to the bathroom, to urinate. They do that, they feel much better. Again, think about obstructive sleep apnea. So far we've talked about some of the signs that we could see in patients with obstructive sleep apnea, and what are some of the cardiac signs that could also point to obstructive sleep apnea. And these are all very important to take note of. How about physical findings in obstructive sleep apnea? Could you look at someone and tell if they have sleep apnea? Well, I know I listed obesity here, but I want to clarify this. You can have obstructive sleep apnea and not be obese. I'll say that again. You can have obstructive sleep apnea and not be obese. But for the most part, most people that are obese, because they have an enlarged neck, a lot of visceral fat, that could also predispose to obstructive sleep apnea. So most people that are obese tend to have obstructive sleep apnea. How about the neck size? I know many anesthesiologists, when patients coming to have surgery, the first thing they look at is their neck size. And also they often have you open your mouth so that they could look inside. Well, in females, if your neck size is over 15 inches, that puts you at risk for having obstructive sleep apnea. If you are a male and your neck size or your shirt size is more than 17 inches, again, that puts you at risk for obstructive sleep apnea. And there are also certain jaw and facial features that also put you at risk for obstructive sleep apnea. You could have your septum in the nose could be deviated to one side. That again could affect your breathing. Your jaw could be retracted such that the bottom of the jaw is pushed backwards. That could predispose to obstructive sleep apnea, and just a narrow airway. That's why sometimes the anesthesiologist, before they put you to sleep, or even when you go to the doctor, they may ask you to open your mouth. And what they're looking for is to see how crowded the back of your throat is. Does the tongue take up most of that space? Does the tongue fall back? Because if it is, it means when you lie back at night, that could also be contributing to obstructive sleep apnea. So sometimes physical findings can, but the one that's often missed are those people that are not obese. They may weigh 100 pounds and they still have obstructive sleep apnea because although their neck size is small, it's still crowded back there and it predisposes them to obstructive sleep apnea. So sometimes physical findings, yes. Now on this slide, this brings me to the array of things that can happen if you do have obstructive sleep apnea. We talked about obesity, upper airway dysfunction, respiratory instability, that in and out breathing irregularly at night. This can cause several things. That first, increased sympathetic nerve activity, that is the fight or flight, increase in your heart rate. There are several metabolic abnormalities, and we'll talk about one, diabetes, and you will hear at length about it from the next speaker. Then sleep apnea can cause inflammation. And so sleep apnea, if you already have any disease process that is inflammatory, sleep apnea can aggravate that. We also see that the sleep apnea can affect the lining of the blood vessel, and that's important as we talk about heart attacks and strokes. And we said earlier, obstructive sleep apnea, you have those episodes where you stop breathing. When you stop breathing, enough oxygen is not getting to the brain. And so you could see all these things can cause you to have high blood pressure, heart disease, and abnormal rhythm. And the one we'll talk about is atrial fibrillation. And finally, end stage cardiovascular disease. So it's important because we know that cardiovascular disease is the leading cause of death for both men and women. So if we now find a risk factor that can predispose you to heart disease, it is incumbent upon us all to be aggressive in ensuring that we are addressing that risk factor, which I like to call the sleeper, which is sleep disease or obstructive sleep apnea. So what are some of the effects of obstructive sleep apnea, or I should say untreated obstructive sleep apnea on heart disease? As seen here, you could see it can affect high blood pressure. It can cause an abnormal rhythm. It can predispose to congestive heart failure, coronary artery disease or blockage in the arteries. It can cause a stroke and diabetes. So these are all of the things that we're going to be talking about now, and we'll take each one individually such that we can come up with some takeaways at the end of today. Let's begin with high blood pressure or hypertension. This slide simply shows that as the severity of your sleep apnea increases, you are at increased risk of having high blood pressure. Very simple. Severe obstructive sleep apnea puts you at risk, a higher risk of having high blood pressure. If we look at the next slide, It's important to know that the relationship between high blood pressure and obstructive sleep apnea is bidirectional. What do I mean by that? If you have obstructive sleep apnea, you are 50% chance of having high blood pressure. 50% chance. So obstructive sleep apnea, 50% chance of having high blood pressure. On the other hand, if you have high blood pressure, you have a 30% chance of having obstructive sleep apnea. So you could see high blood pressure is key. And that is why most people presenting with high blood pressure on more than 3 medications in my clinic, they are all ALL tested to ensure that they do not have obstructive sleep apnea that is driving that high blood pressure. Resistant high blood pressure, we talked about that when you have more than 3 drugs. And if you have resistant high blood pressure, look at that, 87% chance of having obstructive sleep apnea. So this again is important. So high blood pressure on drugs, not treated, well, how about checking to make sure you do not have obstructive sleep apnea? And there's lots of data to show that treating obstructive sleep apnea, and we'll talk about some of those treatments, CPAP is one, can improve the management of your high blood pressure. I've actually had patients that had both high blood pressure and obstructive sleep apnea, treated successfully for their obstructive sleep apnea, that were able to decrease the number of blood pressure medications they were taking because of better management of their obstructive sleep apnea. And that is why when you look at the report from the Joint National Committee in terms of the prevention of high blood pressure, sleep apnea is listed as one of the identifiable causes of high blood pressure. And this is according to the National Institutes of Health. So there are other things that you look for, but definitely if you have if you have resistant high blood pressure, you definitely always want to make sure that sleep apnea is not a contributor. I cannot emphasize this enough. How about abnormal rhythm? We talked about high blood pressure, the fact that it's bidirectional. If you have resistant hypertension, it's important to make sure you do not have obstructive sleep apnea that's contributing to that. Abnormal rhythm in the heart, and that could come from the top of the heart or from the bottom of the heart. The one that is most associated with obstructive sleep apnea is atrial fibrillation. An atrial fibrillation is just a big word for an irregular rhythm that originates in the top chamber of the heart, which is called the atrium. And atrial fibrillation also can predispose you to a stroke. This slide simply shows that if you have obstructive sleep apnea, that broken line, your incidence of atrial fibrillation is higher than if you do not have obstructive sleep apnea. So there's a direct correlation between atrial fibrillation and obstructive sleep apnea. And the reason for that is because now we have lots of fancy things that we can do for atrial fibrillation. You can go into a lab, you can apply electricity across the chest and get you out of the rhythm. You can go into a lab and you can have the electrophysiologist, I like to call the electrical cardiologist, ablate the area that's causing the atrial fibrillation. But I have news. In spite of all those fancy things we have available now to treat atrial fibrillation, we also know that if you have atrial fibrillation as well as obstructive sleep apnea, and it is not treated successfully, that atrial fibrillation is going to come back or recur. So in review, 50% of patients with atrial fibrillation have obstructive sleep apnea. So if you currently have a diagnosis of atrial fibrillation and you have never ever been checked for obstructive sleep apnea, that's the second question to ask your doctor on your next visit. Do you think I would benefit from testing for obstructive sleep apnea to see if I have obstructive sleep apnea that's driving my atrial fibrillation. Now, 80% of the general cardiac population have obstructive sleep apnea. But in atrial fibrillation, 50% of those patients have obstructive sleep apnea. The next statistic is important: 82% recurrence rate. If you have obstructive sleep apnea and atrial fibrillation, after all those fancy testing, the shocks, the ablation, if you do not treat the sleep apnea, guess what? The atrial fibrillation is going to come back. And I just had a patient yesterday. I treated him 1 month ago by cardioversion for his atrial fibrillation. And I was called to see him yesterday at the hospital. The first question I asked him when I saw him was, have you been using your CPAP? He bowed his head and admitted, Doc, I have not been using my CPAP. And I know I'm in trouble because I suspect that is why I am now back in atrial fibrillation. And he was correct, because he was back in atrial fibrillation because he got tired of using it and thought he could put it aside. Now, what's the mechanism of that? Like I said, the atrial fibrillation originates in the atria, which is that upper chamber in the heart. Now, that upper chamber in the heart can increase. You remember with obstructive sleep apnea, you have these episodes throughout the night where you're not getting enough oxygen, or your oxygen level is dropping. That causes that upper chamber in the heart to stretch, and that stretch of that chamber can predispose to atrial fibrillation. So again, atrial fibrillation and obstructive sleep apnea are tightly linked together. And this was the study that they did that showed that patients who were treated for their obstructive sleep apnea after uh, ablation or cardioversion, they did much better than those people who were not treated, because those who were untreated, there was recurrence of their atrial fibrillation. So if you're going in and out of atrial fibrillation, if you've been ablated more than once, you've had several electrical cardioversion, it's time to take a look at what else could be contributing to your atrial fibrillation. What about congestive heart failure? Congestive heart failure is a conglomeration of symptoms, but congestive heart failure you can have if your heart doesn't pump very well, but you could also have congestive heart failure if your heart pumps very well. So the function could be good or the function could be poor. And what often happens in this condition is that fluid builds up in the back of your heart. So in the lungs, I should say, you get short of breath, you could have distension of your abdomen, you could have swelling in your feet. All those are constellation signs of congestive heart failure. But 26% of patients with congestive heart failure often have moderate to severe obstructive sleep apnea. And although the type of sleep apnea they may have is what we call central sleep apnea, which is more coming from the brain, as it suggests, they often have obstructive sleep apnea. And if you do not treat this obstructive sleep apnea, as we saw earlier, these are the patients that wake up at 2 a.m. in the morning, can't breathe, have to be rushed to the hospital to get that medicine so that they can get rid of the fluid so that they could breathe freely again. So congestive heart failure, very, very important, is another risk factor that we see in patients who have obstructive sleep apnea that is not treated. How about coronary artery disease? Coronary artery disease is really blockages in the arteries that feed the heart. And in coronary artery disease, obstructive sleep apnea is associated with an increased risk of a heart attack. Yes, I did say that. I said a heart attack. So if you have obstructive sleep apnea, not been treated, you are at risk for a heart attack. You may say, well, how does a heart attack relate to obstructive sleep apnea? Well, obstructive sleep apnea, like I mentioned earlier, can cause several changes in the vessel of in the blood vessel. One of the things that obstructive sleep apnea causes by that constant decrease in oxygen, it can cause the blood to become thickened. And that thickened blood flow wherever it is, whether it's in the heart or in the brain, can lead to a heart attack if it's in the heart and a stroke if it's in the brain. And there have been studies that show as you have increased obstructive sleep apnea, it also causes you to have increased plaque in the vessel. And a heart attack happens when that plaque in the vessel ruptures. So unfortunately, there have not been a lot of studies done in terms of coronary artery and an obstructive sleep apnea. Few studies, and so studies are ongoing so that we can have more data. But coronary artery disease is absolutely linked to obstructive sleep apnea. And again, the mechanism, like I said, because of that decrease in oxygen that you can have increase in inflammation in the blood vessels that leads to it, decreased blood flow to the heart itself that can cause the heart attack, and also, again, coagulation factors that lead to that increase in clotting in the vessel and the lining of the vessel that can lead to a heart attack. Why am I saying this? Because we always think everyone who dies at night died of a heart attack. Well, if you look at this, between midnight and 6 a.m., most people who die during that time, they die from obstructive sleep apnea. During 6 a.m. and 12, those are the people who die from regular myocardial infarction that's not necessarily associated with obstructive sleep apnea. And it's important, I'm showing this slide just to emphasize the fact again that not everyone that dies in their sleep is dying from a heart attack. They could have died in their sleep because they have obstructive sleep apnea, and that mechanism that wakes you up when you are having these apneic episodes or when you stop breathing did not work. And that's what happened with Reggie White, the famous footballer who died of complications of obstructive sleep apnea in his sleep. Again, in review, heart disease, we said, is the #1 killer in males and females. And death from heart attack typically occurs between 6 a.m. and noon, but deaths from obstructive sleep apnea is between midnight and 6 a.m. in the morning. What about stroke? We talk about stroke like heart attack. Again, it predisposes to obstructive sleep apnea predisposes to stroke because stroke, again, you could have inflammation at the level of the blood vessels in the brain. You could have increased clotting of the blood vessels in the brain. Again, you could have atrial fibrillation as a result of obstructive sleep apnea that predisposes you to a stroke. So you see there's several things that can lead to a stroke if you have obstructive sleep apnea. This slide just reminds us that over 750,000 strokes a year. And of these, 72% of patients that have strokes have obstructive sleep apnea. I've had many patients that had a stroke, never had high blood pressure, diabetes, or high cholesterol. Only thing they had was severe obstructive sleep apnea that was not treated. So remember, obstructive sleep apnea can precede the onset of a stroke. And we heard earlier how snoring can affect the vessels in the neck. And those vessels in the neck can become clogged and predispose again to a stroke. So stroke and the mechanism is very similar to what we see in heart attacks. We talk about the inflammation, the blood increase in coagulation, the hypoxia, and the high blood pressure. So important again that if you have an AHI or an apnea-hypopnea index, or you stop breathing more than 5 times in 1 hour, you are at a higher risk of having a stroke as opposed to those that have a normal breathing pattern in their sleep. That slide just reminds us. And finally, diabetes, which I wouldn't address in depth because the next speaker is going to tell us all about diabetes. But just in summary, we need to know that obstructive sleep apnea can cause decrease in the glucose tolerance and in our ability of our bodies to produce or release insulin. And so it is closely related. I will not steal the thunder of the next speaker, and I will leave him to expound on diabetes. There are other metabolic conditions other than diabetes. We talked about obesity, but there's polycystic ovarian syndrome that we often see in women that can predispose to, that's a risk factor, I should say, for obstructive sleep apnea. If you have obstructive sleep apnea, you are at risk for having that and needs to be addressed. I know as you've been hearing me talk for the last few minutes, you've been wondering, wow, some of these things sounds like stuff that I have. How do I get tested for sleep apnea? Well, that's a good question. There are several ways of testing for sleep apnea. Now, most of the sleep testing is done at home, and there's several things that you can use. You can use in the top left, the watch pad is a device you put on your finger that monitors while you sleep. The top right, this one goes on the forehead. And the one on the bottom is where you use an effort belt that goes around the chest, and you are monitored while you are sleeping in your own environment at home. There are still some that do sleep testing in labs, and there may be labs across the Caribbean where you have sleep testing done. But home sleep testing or in-lab testing is the way to diagnose whether you have obstructive sleep apnea or not. Now, so you've had the test, and now you've been diagnosed with sleep apnea. Finally, I will share with you just what are some of the treatment for for sleep apnea. Well, the first one is we mentioned earlier that obesity is a risk factor. It's clearly shown that people who have weight loss surgery or have lose weight by other methods this can improve their obstructive sleep apnea. They can go from severe to mild, and also just changing your position. It tends to be worse when you lie on your back. Previously, they used to treat men with a brassiere that's put on backwards, and in the back of the brassiere you put tennis balls. So every time they lie on their back, it's uncomfortable, so they roll over on the side. So change in position, because when you lie on your back, it tends to be worse. So change in position, weight loss, these are some methods that may work. But for other people, they need more than just weight loss and sleeping on the side. And so there are other treatments if you have mild or moderate obstructive sleep apnea. There are devices that the dentist can make that are adjustable. That's important. Has to be adjustable, that you can use or put in your mouth when you go to bed at night. It's like a mouth guard. And what that does, it pulls your jaw forward such that it opens the back of your throat while you are sleeping to enable air to go in while you sleep. So this is another way of treating obstructive sleep apnea, a dental appliance that is put in your mouth when you go to bed. Another way of treating obstructive sleep apnea is with a CPAP machine. And the machine is usually there is an attachment to the face. There's a mask, and those masks come in different forms. It can go just on the nose. It can go on the nose. It can go in under the nose. It can go over the nose, or it can go over the nose and mouth. And it's connected to a machine that pushes air in while you are sleeping to keep the back of your throat open. So this is CPAP, and some people need CPAP, some people need bidirectional pressure or continuous pressure. So this is another way. And the CPAP therapy has been shown in several studies to improve your quality of life, and not just your quality of life, but the quality of life of your bed partner. So now the bed partner can sleep because you're no longer snoring, and the quality of life of everyone in the room is improved. Better blood pressure control, we talked about before. It can also decrease that abnormal rhythm and enable you to stay in rhythm after you've had all the fancy treatment, whether it's cardioversion or whether you've had ablation or any other therapies for your irregular rhythm. It can improve cardiac function in those patients that have heart failure with decreased function. It can improve life expectancy in patients with congestive heart failure. And as I shared the story earlier, it can improve memory, which is a good thing these days, especially with all the dementia that may be floating around. This therapy it's a little different. This is a different type of therapy used to treat obstructive sleep apnea, and this is just one device, and this one is called Inspire. But in this therapy, there is a stimulator that is inserted under the right clavicle, and it is stimulates the hypoglossal nerve, and that's a nerve that feeds the muscle that can prevent the muscle from constricting when you are asleep. So how this works is when you go to bed at night, there's a little device right next to your bed that you turn on. So this is turned on when you go to bed, and when you wake up in the morning, you turn it off. And when you turn it on at night, it's stimulating that muscle, that nerve under the chin, and it keeps the back of the airway open. So in summary today, as I close, I want to remind you all, obstructive sleep apnea is a risk factor for heart disease. And we've seen that obstructive sleep apnea has a bidirectional relationship to high blood pressure. It's useful it's 50% of patients that have atrial fibrillation also have obstructive sleep apnea, and that if you can treat that obstructive sleep apnea, it can enable you to stay in sinus rhythm after cardioversion or after ablation. We saw the relationship of obstructive sleep apnea in congestive heart failure, in strokes and heart attacks, in people who have coronary artery disease and diabetes. And diabetes, we'll hear more from our next speaker, but the bottom line is it can be treatable. It is treatable if you first identify it by testing, and once you find out that you have it, it's important to be treated. And on the next slide, the two questions that I would ask. Do you think you are at risk for sleep apnea? Well, if you are, you need to get tested today to prevent heart disease. So again, I thank you for your time, and I hope you took notes and you have questions ready for your physician on your next visit. But just to remind you, as we reflect, I'm going to put up the signs again for obstructive sleep apnea so you can review to see if any of these signs apply to you. And thank you again, and back to you, Mr. Arno.